Okay, next candidate.
Yes, sir. Assalamualaikum, sir. And next.
Salam. 5-year-old female patient, painless mass in the abdomen.
Okay.
Go on.
Okay. Sir, I'm provided with the X-ray KUV or abdomen frontal projection. Sir, I can appreciate that there is an homogeneous density seen overlying the left renal area. It is
Yes.
causing displacement of some bowel inferiorly, and I can't appreciate renal shadow behind it. It's the homogeneous smooth density on the left side with minimal scoliosis of spine as well. It's displacing bowel lobes inferiorly. Apart from this density, I can't appreciate any calcification within this density. And there is no air lucency or low density within it. So I'm suspecting a mass lesion which is which is super overlying the left renal area. So I want to further proceed with this patient with the
Doctor,
ultrasound.
raise your voice a little bit, please.
Okay, sir. Okay, sir, I'm suspecting an large mass lesion which is seen overlying the left renal area. So I want, it has no calcification or any fatty component. So I
Excellent.
would further proceed this X-ray with this patient with the ultrasound to check the either it is in the adrenal origin or is in the lumbar region. But I'm suspecting lumbar renal lesion because it is left renal shadow is not visualized. So it also there's a bones appears to be fine. Very minimal scoliosis is there, and I no air lucency or free air within this abdominal X-ray. So I'm suspecting a left renal mass lesion.
What is your next step?
So next I would proceed with the ultrasound. Or
Okay.
sir, I also any bony abnormality will also be if lateral available or any other imaging available. I will check, but ultrasound will further. Oh,
Could you request control, please?
yes, sir.
Request, yes.
Yes. Okay, sir.
By the way, my colleague, the correct next step is ultrasound. But don't be afraid or don't confuse if you request ultrasound and the
Okay.
examiner give you a CT. You are correct,
Sir,
but he wanted to examine you in a CT. Why I'm telling you like this? Because this situation has been happening with me. I request correctly ultrasound and I think he gave me MRI or CT, but I confused. I told myself, what is this? I'm wrong or not? No, you are correct. Go on, doctor.
okay. Sir, I'm provided with the CT axial non-contrast images.
Yes.
In this CT, I can appreciate that there is a huge mass lesion, which is seen involving the left kidney because I don't find any renal tissue in this plain study. There's no calcification in it. It is causing significant mass effect over the adjacent structures like bowel and psoas muscle. But this I don't find any calcification. So I would further proceed this CT scan with the contrast image to check the like vascularity of this mass lesion. Also lymph nodes. I want to check contrast images. Sir.
Take the contrast. Take.
Okay, sir. Okay, sir. So these are the contrast images. Oh, so in this image, I can appreciate that there is a large solid mass lesion seen involving the left kidney with some claw signs is there, sir, and some stretching of the vessels. It is not crossing the midline.
Yes.
Yes. Okay. Sir, I want to check venous phase as well to check the thrombosis or renal vein involvement. Can I check some venous system?
Yes. Go on.
So in this, Okay, sir. So in this venous phase, I can appreciate there's a large thrombus, which is small, extending from the left renal vein up to the intrahepatic IVC.
Excellent.
However, the atrium, no involvement, supradiaphragmatic involvement is not there. It is infradiaphragmatic involvement of the IVC. Also, sir, there is a stretching of the vessels, but no midline shift is there. Also, I want to check the liver as well to check any metastatic lesion in the liver, but in this
So,
image,
what do you think
okay,
of?
sir, sir, I'm suspecting a neoplastic mass, which is most likely in this age group glimpse tumor, because it is not crossing the midline, but and also shows vascular invasion. The more primary mass lesion, I'm suspecting Wilms tumor,
Yes.
and so, okay, so this requires proper CT staging of the chest as well as bone and other lesion. I'm suspecting also liver metastasis also in this segment. So there is an area of hypodensity.
Yes.
So I'm suspecting
Where?
this is
Where?
a
Show me, please.
metastatic.
No, no, no. Show me, please.
Sir, this okay, sir, this around the falciform ligament
I
there is
think
some
no, no,
hypodensity.
no, no. I think
Um,
this is normal variant. By the way,
uh,
it has a specific name, but I didn't get it now. Okay, what else?
uh, Sir, I want to check lung windows to send pulmonary mats as well, and some lumbar spine lateral sagittal
Why?
image to
Why
those
this
mats
mass?
also.
Why this mass not uh, nephro neuroblastoma? Sorry. By
Sir,
the way,
neuroblastoma usually
by the
don't
way,
invade the vessel.
by the 1 second. By the way, Wilms tumor has another name. Has another name. Anyone know it? Is this name?
Sir, nephroblastoma.
Nephroblastoma. Wilms tumor is may be called nephroblastoma. But why is this not a neuroblastoma? Could you give me some differentiation between Wilms tumor and
Okay,
neuroblastoma?
sir. Okay, sir. In neuroblastoma, calcification is more on neuroblastoma. Neuroblastoma crosses the midline and they cover on the other region. Vascular invasion is more in Wilms tumor apart from nephroblastoma. Nephroblastoma give, sorry, neuroblastoma give more bone mets and nephroblastoma give more pulmonary mets. Calcification is more common in neuroblastoma than nephroblastoma. Midline crossing is also in neuroblastoma as compared to nephroblastoma. Claw sign and renal origin is more visible in this Wilms tumor as compared to.
Excellent. Excellent. What about the age of patient?
So yes, age in neuroblastoma usually less than 2 year, 2 to 5 year more commonly in neuro, and Wilms is little more 3 to 8 year is more commonly for Wilms tumor, little older.
Again, please be according to age because it is very important. Very important. Again, tell me about the age.
So neuroblastoma usually less than 2 years, 2 to 3
Okay.
or 2 to 5 year, and then Wilms tumor mostly 3 to 10 or 3 to 8 years are more common, older age.
Excellent, doctor. Really brilliant. Brilliant. Thank you so much. Doctor, if it is a case of Wilms tumor, why? Look here. The mass, the mass is inside the kidney. No need even to talk about the claw sign, despite it is a claw sign, but it is very obvious. Okay? Large, not crossing the midline. And what about the vessel? Look here. Just displacing the vessels. The neuroblastoma encasing the vessels. Number two, very huge renal vein. See, impossible. What is this? And IVC infiltration. Incredible infiltration. Incredible thrombotic tumor thrombosis. Incredible. So it is Wilms tumor. Wilms tumor is very common to metastasize to the lung and maybe the liver. However, neuroblastoma metastasize to the bone. Opposite. Okay, my colleague. Thank you, doctor, so much. Calcification is common in neuroblastoma. Thank you, doctor, so much. Next candidate. Next candidate. Hello.
Assalamu alaikum, sir.
Alaikum salam. Doctor,
Okay.
this patient is 3 years old, has left gate abnormality. Go on.
Okay. Sir, I'm provided with the X-ray pelvis, frontal projection of a skeletally immature patient, in which I can appreciate that there is lucency noted in the left upper femoral shaft, and
Okay.
uh, I would like to review it on the orthogonal view if available. Okay. In the orthogonal view, I can again appreciate that there is lucency with subtle areas of cortical irregularity noted along the upper left femoral shaft. The contour of the femoral head is unremarkable, with no subcondylocencies or erosive changes noted in this. Rest of the visualized bones appears to be unremarkable. So, lucent lesion which is involving the left upper femora, and I would like to correlate my findings with the clinical history. Any previous radiograph is available, and it's a
Doctor,
uh,
doctor, you are
yes,
describing very well, but you didn't give me a clue. Is this aggressive or non-aggressive? This is
yes,
the,
sir. I'm coming. I'm coming over. So it is the upper margin of this lesion is not well defined, and it is
yes,
showing wide zone of transition. So I
yes,
would label and subtle periodic reaction as well. So
yes.
it's an aggressive looking lesion, and I would advise MRI for further management.
Thank you. I will give you one notes before we leave it. See, what is the examiner want from us? He wanted to describe this is a lucent and is a site proximal
Yes,
metaphysis or neck of the left femur, and it is ill-defined or wide zone of transition. And
yes,
let's see this one. It looks like maybe some irregularity here in the cortex
irregularity.
and
Yes,
some soft tissue. Doctor, this is aggressive. He want
yes, sir. This is aggressive.
three, four maximum sentences and stamp it by your conclusion. This is the most
Okay, sir.
important.
Okay,
Okay?
okay, sir. Okay.
Okay. What will you do next?
Sir, I would like to previous radiographic clinical lab correlation and then sir MRI of this region for further evaluation.
Okay.
So now I'm
Could you
provided
request
with the
control,
MRI.
Dr. Omer, please?
Yes, sir.
Request control, please.
Okay. Um, Sir, I have requested it.
Go on.
Okay. Sir, now I am provided with the coronal fat set images
Yes.
of bilateral knee, and in this I would examine all the images before commenting. And so the muscles, subcutaneous tissue, soft tissue appears to be unremarkable, and so there are altered bone marrow edematous changes noted in the visualized bilateral lower femurs, and I would like to review it in the axial images and further images involving the involving the femur to confirm my findings.
What next sequence do you want? Tell me.
Sir, I want to examine the the femora, bilateral femora. Look for these signals. Are they real and are they
Yes.
involving the whole shaft or patchy signals and then um,
This is
axial and then the exothecus. So now I'm provided with the T1 uh, post contrast images of the bilateral upper femora, and now I will. scroll, jumping a bit. So there are altered marrow signal intensity areas with enhancement noted in the soft tissue associated component, also seen in the bilateral upper femora and in the uh, femoral shaft as well, and in the bilateral view in the bilateral visualized hip bones as well. I would now examine the lower spine and other uh, bony areas as well. And I would, sir, if the axial images are available, I would like to examine them in the axial images as well. These are also showing post-contrast enhancement. And sir, this is a diffuse process which is involving the both of the femora. Sir, I have three differentials for that: leukemia, lymphoma, or metastatic deposits. I would like to see in the axial images as well.
Okay, 1 second.
Okay, so these are the axial images, and which again starting from top and scrolling, I can again appreciate okay, I would the visualized lower abdomen and the pelvic viscera. They are unremarkable, and alter marrow signals are. It is, I don't know. Okay, yeah, are noted in the bilateral femoral shafts and with a small associated soft tissue components also seen. And okay, sir, my differential remains the same, and I would refer the patient um, to
What's
sarcoma
your
center.
differential again?
Sir, leukemia, lymphoma, and
Okay, Dr. Omer,
yes.
my advice to you, there are a clue of the primary in the images, in the edge.
Okay, sir.
This is a film
Okay, sir.
edge.
I would,
Look,
sir. I tried to examine the kidneys. I would examine them once again. Okay, wait. And the scrotum as well.
excellent. But this type of leave the mouse, I will help you.
Okay, 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 okay.
This is a bone metastasis. So
Yes, sir.
which part, which anatomical part do you want to examine?
Sir, the kidneys and the specifically for the evidence of neuroblastoma.
Better look here.
Uh, okay. So there is and the scrotal area and for any germ cell tumor as well. And sir, I guess there is in the right kidney.
Excellent.
Yes, sir, it's
Brilliant.
bulky. It's pretty bulky. Yes, sir. I
Mhm.
would examine it further via ultrasound.
So give me a differential.
Sir, now the top differential is metastatic deposit and neuro likely from the renal primary and
Look at the
uh,
age. Look
sir,
at the
age
age.
is 3 years. Yes, sir.
And bone metastasis. What is the
Yes, sir.
most excellent? Excellent.
Neuroblastoma. Yes, sir.
See, my colleague,
Neuroblastoma.
despite really it is not clear, is this, look here, is this the kidney or is this the suprarenal? But from the age
Mm.
and from the type of the metastasis, you can expect. Thank you, Dr. Umer. My
Thank you,
colleague,
sir. Thank you, sir.
in my career, I think no any exam that I have in my career without a film edge case. Even really, no. First exam for me, it was a master in Egypt, a case of para-aortic lymph node, and the last cut, very thin cut. It was just a small testicular lesion. Here also, and I sent twice in the FR in the long reporting. Two film age, very important. See, very important. Okay, here this is a left renal or suprarenal mass. Okay, why? Description of this bony metastasis is very easy. The examiner, see, the bone is completely infiltrated. The examiner want from you as a potential consultant of radiology what beyond the norm, يعني the standard. He want from you, see here, this kidney is not like this. This is not like this. Okay, my colleague, see? Here, much better. Much better. I think this one. Maybe. So it was a neuroblastoma with bone metastasis. Thank you, Dr. Omer, so much.
Thank you, sir. Thank you so much.
Dr. Omer, you didn't told me after ultrasound if you find neuroblastoma, what's your next step?
Sir, after ultrasound, sir, staging of staging CT, and then sir, histological correlation.
What about MIBG?
Oh, sorry. Yes, sir. MIBG scan too. MIBG.
Okay. In neuroblastoma, are we need a bone scan or not?
And sir, MIBG scan would be enough.
Okay, okay. See, we will do MIBG. Okay, no any doubt. But
Yes.
what about the other regular bone scan?
Sir, I don't think I haven't heard of it because the neuroblastoma don't uptake the MBP test.
No, see, okay, okay. I will explain something. Okay. See, my colleague, because thank you, Dr. Umir, very much for your
Thank
nice
you, sir.
description. My colleague, Dr. Umir, is one of the talented radiologists in description. He is a descriptive, and his style is amazing. Uh, all of us can learn from him. I will add a little bit information. Next step will be MIBG and technetium, the regular bone scan. Technetium MDB. Why? Because at least 36% of the metastasis of the neuroblastoma is not uptaking the MIBG. See my colleague here. Hey, this is the Radiopedia. Sorry, I'm using why I'm showing you the textbook, because this is very critical for all of you to be 100% the information is clear and concise. See, this is the neuroblastoma. Consider about 40% didn't uptake this MIBG. See, what will happen? What will we do in nuclear medicine? Okay, MIBG or octreotide scan, Indium 11, all of these are analog, no problem. Okay, but the most important and the most of us forget it, bone scan, MDB bone scan. Why? Because 36 or 40 of the primary tumor, what means negative? Negative to MIBG. Okay, my colleague, this is very important, my colleague. By the way, neuroblastoma have a bone metastasis prediction, and it may originate from suprarenal or extra-suprarenal, like sympathetic chain. Where is the sympathetic chain? In paravertebral location. Okay, my colleague? Paravertebral location in the sympathetic chain along the thoracic and the lumbar, anywhere from this parasympathetic or sorry, sympathetic, from the sympathetic chain. Thank you so much. Next candidate, Dr. Omer, I have last question. Neuroblastoma is neuronal secreting or non-secreting tumor?
Sir, sorry. Can you repeat the question?
Neuroblastoma is neurogenic secreting or non-secreting tumor?
Sir, it is a sir. I don't have the exact idea, but I think it is a secreting tumor.
Yeah, correct. Is neuroblastoma is secreting any type of catecholamines and any hormones? This is a
Yes, sir.
question.
HI, sir. Pendial PMA and sir, I forgot the exact name. EMA and HIA.
Yeah, it is secreting. At least it's
Yes,
secreting. Okay,
yes, sir. Yes. Thank you.
secreting. Okay, thank you so much. It is very important. Why? Because the patient may have يعني a different or atypical presentation, not an oncology presentation due to these hormones or these materials that's secreted by the tumor itself. Thank you, doctor, so much. Next candidate,
Thank you, sir.
Hello.
welcome. 2-year-old male patient presented with abdominal distension. Can you request control, please?
Sir, I have requested remote control.
Raise your voice little bit, please.
Sir, I said I have requested remote control. Can you hear me now?
One second. I will leave this. I will remove this. Leave. I will remove this. Leave. Go on.
Okay, these are contrast enhanced CT examinations, abdomen of pediatric age group patient. I can appreciate that both kidneys are markedly enlarged and they show low density renal cortex. They are approaching to the pelvis, bilateral pelvises. The contrast is, however, the medullary portion is, however, taking the contrast. In the I'm looking at the vessels. The both the renal veins, they are normally opacified. Both the spleen and the liver, they are not showing any focal lesions. So in this patient, in this pediatric age group patient, there is marked enlargement of the bilateral kidneys with the poor enhancement of the bilateral renal cortices. I
Do
am
you
looking
think,
for
doctor,
the
one second.
enlargement.
1 second. Do you think all
Yeah,
of
yeah.
these are cortex?
Sir, I am looking. I am suspecting some infiltration of the
Okay.
masses by this cortical. That's why I am looking for the
See.
enlarged lymph nodes.
Doctor,
I am
1 second.
also
1 second.
sorry.
Better to inform the examiner. This is a parenchyma. Leave the mouse. This is a parenchyma. Okay. Why? Because it is impossible. All of this is cortex. Okay.
Okay,
Are you agree with me?
okay,
Go
yeah.
on. Go on.
I am looking for the enlarged lymph nodes. I think these are. I am also suspecting some enlarged lymph nodes in the parotid regions. So my principal diagnosis in this case is some tumor infiltration of the bilateral kidneys. It could be a case of lymphoma or leukemia. Um, Other differentials, the less likely differential in this case would be bilateral nephrotic nephrotic syndrome. So I will
Nephrotic. What else?
nephrotic
Okay.
and
Okay. But where is the lymph node, doctor? Show me the lymph nodes, please.
I was suspecting either this is the renal parenchyma right over here. Yeah, this is the renal parenchyma. I was suspecting right over here. No, this is, I think this is the renal parenchyma.
So there are lymph node or not?
So I think there are no enlarged lymph nodes.
Excellent. So you can exclude lymphoma.
Okay, so these are leukemic infiltrates in the bilateral kidneys,
Do you remember?
and
Do you remember the age of patient?
so it was, I think, 2 year.
Okay. Give me some different. And so this is not
Other
lymphoma.
differential,
This is not
other
lymphoma.
differentials in this. Okay, other differentials in this case would be nephroblastomatosis, bilateral
Excellent.
renal nephroblastomatosis.
What is
Uh,
nephroblastomatosis?
there are bilateral nephroblastic tissues, and some of them convert into
Brilliant.
the Wilms tumor.
Brilliant. Yes, this is a plastemal cell abnormality. Okay. Okay.
Okay.
Persistence of the metanephric blastemus. Okay. Doctor,
Okay.
what do you think the most possible management and why?
Sir, I will.
I will take the history of the patient. I will compare with the previous imaging if available, and also I would suggest referral to the pediatric urology oncology MDT. Also, I would suggest
One
follow-up
second,
imaging
doctor.
to show
Doctor, 1 second.
interval progression of
Doctor,
Wilms
when
tumor.
the examiner asks you a definite question, give him a definite question. Like, I will give you example. We see one tumor. What is the management? Either tell him chemotherapy or resection in a specific sarcoma center. Okay, but it is good, not bad. Our this 2 to 3 sentences that I will inform, I will transfer. Okay, but really, for the examiner, he wanted to listen from you something. I ask you a question. What is the expected management and why? I will ask you the same question, but in another way. What is the expected complication of this nephroblastomatosis?
Sir, there is a complication to convert this nephroblastoma tissue into the Wilms tumor.
Excellent. So, what is
So
the
follow-up imaging?
So, do you think?
Follow-up imaging is recommended.
Okay, do you think their removal is important or يعني resection or not important?
Sir, keeping in view the complication of the tumor, then the preferred treatment should be resection and the transplant, renal transplant in this case.
Excellent. Do you know about 30 to 40%, 3040 transformation? Incredible. So it means half of the patient with nephroblastomatosis will get very soon a Wilms tumor. يعني incredible. And most of them are bilateral, so it is fatal. Even I think Wilms tumor itself has a nephroblastomal origin. Okay? Okay, my colleague. Thank you, doctor, so much. It was a case.
Thank you, sir.
Really, you did very well. It was a case of nephroblastomatosis. Our doctor first suspect in lymphoma and no lymph node, so she bought nephrotic syndrome and nephroblastomatosis. Okay, my colleague. See, but I think يعني nephrotic syndrome will not give this huge kidney. Incredible. My colleague take a home message. Large bilateral kidney and lobulated like this. Okay. Number one, if adult, lymphoma until proof otherwise. Number two, see, very young, very 2-year-old nephroblastomatosis. Okay. Somebody will tell me, doctor, bilateral Wilms tumor. Okay, but this is diffuse and no cystic changes. Okay, my colleague. See, this is يعني residual normal tissue enhanced because it is a post contrast, this one, and all of this non-enhanced blastemal cell. Why? Because it is embryonal cell, it is poorly vascular. Thank you, doctor, so much. It is highly malignant, يعني malignant transformation, about 40% to Wilms tumor. 30-year-old male patient with abdominal distension.
Okay.
Mm.
This is MRI axial view T2 weighted images.
Yes.
And it is showing bilateral kidneys having multiple cystic areas which are high on T2.
Okay.
And there are the sir, can I scroll it?
Yeah.
Can I request to scroll? Okay. So, okay. Sir, I've requested.
Yeah, go on.
Thank you. Sir, it's not scrolling. Please do it for me.
Use arrow.
Yes, sir, I'm trying.
1 second, leave the
Yes,
mouse.
sir.
Leave the mouse. Use arrow.
Okay. Yes, sir, it's not scrolling.
Okay, no problem. See, my colleague, I will tell you something. In FRCR-Viva, I have a big technical problem. And then Finally, the examiner was scrolling for me, and
Yes, sir.
I made a big mistake. Why? I lost my confidence, and I become very depressed inside the exam, and this is not good, by the way.
Right.
Then the examiner are trying to help me. He is trying always, always. And then finally, he told me, look here, look at these slides. The pathology is here. Like this, really, I'm not joking. And because I blocked, I didn't tell him the answer.
Hmm.
See? And finally, when I get the result, they give me good mark according to my answers and the technical problems and everything. If I concentrate more and if I didn't lose confidence and didn't block, I will at least get some finding. They gave me, I think, 5.5 from 6, despite okay, it was a major technical problem, but the examiner tried to cover the technical problem, but خلاص, I lost confidence. So my advice for
Right.
you, and this is very important, if you face a technical problem, talk with the examiner, talk with the beside, there are one woman or one man beside you, and whatever inspector, tell him, try to fix it. They will try, really. Okay. And
Yes, sir.
if the problem is still present, ask the examiner to help you, and don't lose confidence. Really concentrate and be sure that RCR is very fair. They will consider. And after you finish, you must do any complaint, any incident report like this to save your rights. Go on.
Yes, sir. Thank you. So, sir, there are multiple cystic areas in the bilateral kidneys, and I can see some solid rounded lesions in both kidneys as well, which are low
Excellent.
signal on T2.
Excellent.
Um,
What else?
sir, there are multiple cystic areas noted in the body tail of, in fact, the entire pancreas.
Excellent.
Uh, and So there are cysts in the kidneys and pancreas. So I'd like to see this looks like I'm suspecting von Hippel-Lindau's
Okay. What
disease.
what is the name of the sequence?
Sir, this is the gradient echo sequence for blooming
Are you
artifact.
sure? Are you sure? Look
Sir,
at the
is
kidney. Look at the vessels.
this is post contrast?
Okay, one second. My
On fat
colleague,
set, post
one second.
contrast fat set.
Okay, one second, one second. My colleague, my advice for all of you, in any fat set abdomen or pelvis or whatever, or orbit, when you see fat set, first look at the vessel. Okay, this is fat set.
Yes.
Great. Look
Mm.
at the vessels. There are contrasts or not. Why? You can tell the examiner this is post-contrast fat set. Great. Or you can tell the examiner this is fat set. Like this. Very important. Okay? And if
Yes, sir.
you
Yes.
want to know is this T1 or T2 fat set, look here. Look at
Yes,
any
sir.
fluid. So this is not gradient at all. And see here
Yes, sir.
the kidneys. See here?
They're enhancing.
Yeah, go on.
Okay. So, sir, can I see the coronal images, please?
No, look here. What happened here?
Okay. So the para vertebral soft tissues appear prominent, and
Look at the right
I can
kidney.
see.
Right kidney, right kidney.
So right kidney shows altered signals at the anterior aspect.
What
Um,
happened, doctor? See.
so yeah, so this is high signal. This is an enhancing lesion.
Excellent.
Um, yeah. So this is suspicious for any malignancy. Um,
Which type of malignancy, doctor?
so renal cell carcinoma.
Doctor, you just suspect something from here. This is the same patient. Okay.
Yes, sir.
Okay. This is renal cell carcinoma. Where else? Is this
Sir, I'd like to.
1 second? See, don't shift my advice for you from sequence to sequence before you pick up all the findings. See, is this only one mass? And is this only one mass? This one only? You didn't examine rest of the kidney. See, what is this?
No, sir, I can see. Yeah, I
See,
can see. Yes, sir. There are other enhancing lesions in
what
the
is
left
this?
kidney as
What
well.
is this? What is this? So this is not only RCC.
Yes, sir.
It's multiple. Tell me, multiple.
Yes, sir. So these are multiple malignancies.
Yes, multiple unilateral or bilateral, doctor.
Yes, sir.
Yeah, doctor, tell me, multiple
Okay.
bilateral, multiple bilateral renal masses in correlation
Yes, sir.
with this cystis, pancreatic and
Yes,
renal cystis.
and multiple pancreatic lesions as well,
What's
cysts
your
as well.
what's your concern?
Sir, um,
What's your
I am. So there is a liver lesion as well, which is enhancing in the right lobe. Um,
no, no,
so
look, look. This is renal, maybe exophatic. Look,
okay. Yes, sir. Yeah, yeah. So it's
see,
the
see, see,
renal, sir.
this one. So,
Mm.
what is the diagnosis, doctor?
So now, sir, I am suspecting um, this is tuberous sclerosis with the kidney
Oh,
and pancreas and
doctor. Bilateral renal masses. Is this fat? Is this fat? If this fat, see, you here it must be suppressed. This is a T2 fat,
yes, sir.
and then it is enhanced. Doctor, why you change your diagnosis? You start very well. You here,
Yes, sir, I got confused. Okay, you're right. So these are pancreatic cysts, renal cysts, or bilateral renal masses. I will stick to my previous diagnosis of von Hippel-Lindau's disease. The VHL, and I'd
what
like
is
to do
this?
the
Von Hebelendo.
von Hippel-Lindau's disease, and I'd like to see the MRI brain for any brain lesions, and then I'll refer the patient to pediatric oncology um, for
What?
staging.
What?
Sorry,
What will you find in brain lesion? In brain,
sir, hemangioblastoma. I look for hemangioblastomas.
okay. Where exactly?
So cerebellum, most likely.
What else? What other anatomical location could be
Sir,
found?
spinal cord. There can be hemangioblastomas in the spinal cord as well.
Thank you, doctor, so much. Take care, my colleague. Even bilateral RCC is diagnostic or suspicion for von Hippel-Lindau. Even, يعني if you find just one RCC here and one here, you must make a note about von Hippel-Lindau. Okay, but here I
Okay,
think it
thank you.
is pathognomonic. Doctor, why this is not tuber sclerosis? Why? Look at it, at least T1.
Yeah, yeah, sir. It's not fat density and it's not suppressing on fat, sir.
Yeah, and T2. See here,
Yeah. Yes,
all
sir.
the see all the masses here. This is T2 axial T2 fat set. See, this is not fat at all. This is
Hmm.
mass containing cystic changes. It was von Hippel-Lindau case. Next candidate.
Yes, sir. Good evening. I'm candidate 12.
Good evening,
Um,
female
okay.
patient. Female patient who referred for tertiary review at 34 weeks of gestation. So this is, sorry,
oops.
another case. Neonate male, cesarean born 3 hours neonate with abdominal distension. Look here.
Mm,
Look, look. What is this? What is the name of this organ?
it's pelvic kidney.
Yeah. Excellent. What happened for this kidney?
Sorry? Sorry, doctor.
What happened for this kidney?
Um,
What about the size? See, this is
oh,
neonate. What about the
the,
size?
the size is enlarged.
Okay, what about the echogenicity?
There's increased echogenicity.
So, what are you thinking about?
Mm,
Large, echogenic, and I will help you. Both kidneys, this is the left, this is the right. The patient is oligohydramnios. This means this kidney is functioning or non-functioning.
um, since it's echogenic, I feel it's a non-functioning.
Okay, so what's your diagnosis?
Um, we go.
Even the liver, see, the liver is little bit coarse and echogenic. Which disease connected enlarged echogenic kidney with coarse echogenic liver? What is the name of the disease?
Um, um, but it's not cirrhotic, not.
Hmm.
Sorry, sir. Not so sure what is it.
Okay, no problem. This is autosomal recessive polycystic kidney disease. Despite
Oh,
it polycystic, but no cyst you can detect. Why? Because it is micro, very small cysts. So it
okay.
makes the kidney, it makes the kidney enlarged and echogenic. And the liver, there are fibrosis. There are
Okay.
opposite relation between the degree. يعني, if the degree of polycystic disease here is high, the degree of fibrosis is less. There are opposite, but there are association. This patient, this is incompatible with life. This patient
Uh-huh.
is oligohydramnios due to no liquor, يعني. No urine, so no liquor. Thank you, doctor, so much. Don't
Mhm.
worry, don't worry. The cases of pediatric really is very difficult and not familiar. By repetition, you will become more better in pediatric.
Okay. Okay.
This is our case. Okay. Next candidate.
Thank you.
Next candidate.
Hello, doctor.
Hello. Six
Yes.
months.
Hiya.
Male presented with abdominal mass. See, doctor.
Okay. Okay. These are ultrasound images of 6 months years old male with abdominal mass. I can see that um,
This is the region.
the
Kidney.
region of the
This
left
is the,
kidney.
yeah.
There is an oval-shaped, well-defined heterogeneous mass with central cystic degeneration and peripheral and internal vascularity. Um, um, it, can I request control, please?
Okay, this is static image. All of this.
Okay. So it's seen encroaching. Okay, on the renal parenchyma.
Yes.
And so there is mass effect in the renal parenchyma. Um, it's measuring 10.2 by 7.7 centimeters.
Doctor, is this aggressive or
So I would
non-aggressive?
like,
Aggressive or non-aggressive?
it looks aggressive
Excellent, excellent. What
because
about the age?
I can't,
1 second. What about the
it's
age?
6 months, so
Okay,
6 months. So
aggressive mass in 6 months. What's your differential? This is a kidney. I am helping you. See, because it is written down, I think here. Written down here. Here. Okay. aggressive large mass in the kidney, but in neonatal life, very young, in early childhood. What's your diagnosis?
Um, so Wilms tumor comes later.
Excellent. So
So it will not be
we will
my
exclude
first. Yeah.
Wilms.
Uh,
If I told you this is not suprarenal,
so
what will you exclude?
neuroblastoma. So it looks arising from the kidney. So it's not a neuroblastoma
Excellent.
anyway.
Excellent.
So it's maybe mesoblastic nephroma.
Excellent. Really brilliant.
This is my first differential. So
Excellent.
my next step is to request to alert the referring physician and request neurology
What
and
about this?
pediatric neurology MDT and request CT with contrast.
See?
Yeah,
See?
these are
Looks like the
yeah.
same case of Wilms tumor. Really, very similar, but in very young age. Very young. Thank you, doctor, so much.
Okay.
See my colleagues.
Okay.
Doctor, I
Yeah.
have a question. Can I ask
Yes.
you one question?
Yeah. Sure.
I think your style is now better.
Oh, thank you.
Okay? I think that. Do you agree with me?
Maybe.
No, you must agree. Thank you so much. What happened here?
Okay. Yeah.
What happened here, my colleagues? What happened? We have a mess, aggressive mess. See, we built the diagnosis. This is what I want from all of you. A mass, a very atypical mass in very young age, and most of us has no any clue or knowledge or practice in this age. But you presented with this case. I told you before about one case I presented with it in the long reporting. It was really so confusing, and plus يعني the additional exam confusion. It was a HIDA scan, but the bladder, you can see the gall bladder and dilated CBD. What is this? Little bit dilated. What is this? I told myself I'm not an expert in HIDA scan. HIDA scan means biliary atresia. I describe biliary atresia and leave the case. And finally, it was correct. When I go to home, I open Radiopedia, I revise biliary atresia. I find many normal variant, like the gallbladder may be smaller. The atresia may be low at low level, so you can see a little bit part of the CBD like this. So the common is common. Mass. Number one, where in kidney. Number two, aggressive or not aggressive. Okay. Exclude others like يعني both differential diagnosis like wellness nephroblastoma. No, the age is not in the side of wellness. Exclude it. Then this is not nephroblastoma. Okay. Neuroblastoma, sorry. So we make a diagnosis by exclusion. This diagnosis was made by exclusion. Mesoblastic nephroma. Okay, my colleagues, this is what is the ideal technique and style in FRCR when you are presented with a non-familiar cases. Thank you, doctors. How
Okay.
many
Thank you, doctor.
how many candidates is remaining now?
5, sir.
5.
Yes.
I think we take till 12.
Now 14 will proceed.
Yeah. Okay. Next candidate.
Assalamu alaikum.
Wassalam. Doctor, this patient has abdominal distension.
This is the grayscale ultrasound of abdomen.
Yes. what I will help
Uh,
you because there are no time. This is one kidney, okay? This is the other
yes.
one. This is another kidney. So this normal or abnormal?
I will take its measurement if it is a large or normal size. However, it appears normal, but this kidney
Okay.
appears distorted because of
Okay.
corticomedullary differentiation.
Excellent. What happened here? What is this?
Multiple cystic areas with calcific foci are noted.
Okay, this is a true calcification, but anyway. Okay, what happened? What happened?
This distorted kidneys with multiple cystic areas can be multicystic dysplastic kidneys,
Excellent.
sequelae of multicystic kidney.
Okay, excellent.
Yes.
Great. Doctor, when you find one multicystic dysplastic kidney, what you are worried about?
Multicystic dysplastic kidney, any abnormality in the contralateral kidney or association,
Great.
its associations.
Yes, like
PUJ on the contralateral side.
great, doctor. Brilliant, really. Thank you, doctor, so much. This is the most important. Why? Because this kidney, we lost this kidney, non-functioning almost. The most important, the healthy one, it is compensatory hypertrophied, and fortunately, no any hydronephrosis. But you must tell the examiner, BUG obstruction is very common association. Okay.
Yes.
Thank you, doctor, so much. Next candidate.
Good afternoon, Dr. Rami.
Good afternoon. Doctor, this is 30 months male patient, has recurrent urinary tract infection. This is the right kidney. Okay.
Okay.
This is the right
Okay.
vesicureteric junction. This is the bladder. And then after we bought a Doppler box, we saw it. Tell me.
Okay. So I can see that the right kidney is enlarged with hydroerythronephrosis,
Okay.
and the distal right ureter is seen also dilated with
Yes.
reflux of urine.
Excellent.
Yes. So I'm suspecting that this might be reflux nephropathy.
Excellent. Excellent.
I would like to check the left kidney and
Okay. What is your next step?
reflux nephropathy. I can convey my finding to the pediatric team and ask for doing a renal function to check how the renal is functioning and
What else?
correlate with the.
What else to determine the type? Okay.
Yes.
Either renal scan or
Yeah,
CFP. Thank you, doctor.
Yeah.
See, my colleagues, this is the different types. This is grade 1. Grade 1 didn't reach the pelvic calcium system. Here, rich without dilatation. Here, rich with mild, moderate, severe, or ballooning dilatation. From grade 1, 2, 3, 4, 5. Doctor, is this important? Yes. At least you take a general idea. Okay? This is from 3 to 4, from 3 to 5 must have a pelvic cell dilatation. By the way, the vesicureteric reflux may be primary, may be secondary. Okay, maybe primary its own, and maybe secondary to neurogenic bladder. What else? Okay, there are many causes. Thank you, doctor, so much. Next candidate.
Thank you, doctor.
Welcome.
Yes, doc.
Doctor, this is female, 20-year-old female patient has right abdominal pain. Look here, look here, look here, look here. What is the name of this technique?
This is IVB.
Excellent. Give me the
multiple images for the IVB. I can see that there is evidence of 2 kidneys noted within the left side aspect of the abdomen with 2 ureters, suggesting that. Sorry?
Great. Yeah, go.
Suggesting that there is evidence of cross-diffused ectopia. This is a main diagnosis, proper diagnosis for this because I couldn't see the other side. I want to look for the both ureter.
Yes.
This is okay.
I'm helping
This
you.
is the left. Oh, okay. And And
ureter or two ureter?
sorry, it's in the right or in the left, doc, because some images appearing to be in the left and
Look,
some images
look
appearing to
here,
be.
look here.
Sorry, this is Brown. Okay,
Okay.
okay.
So
So
thank you.
this is Brown.
Thank you
So
for
it's in
this
the right
confusion.
aspect.
Yeah. Thank you for this confusion. When we are presented with IVB, please check is this prone or not. And
Okay.
most type of contrast, my colleague, is even barium. Sometimes the barium
Okay.
and the CT interrography may be in prone position. This is very important. Okay, doctor.
Okay.
One ureter or two
Yes.
ureter?
It should be two ureters, one in
Here?
the right side and one in the left.
Yeah,
Yes.
two ureter. Okay, doctor.
Yes.
Again, the diagnosis. Repeat the diagnosis.
Cross-diffused ectopia.
There are
Cross-diffused
fusion
ectopia in the right aspect.
between the lower pole of right and the upper pole of left kidney. Thank you so much, my doctor. This patient, if he has a trauma here, he will be unlucky. Both kidney may be damaged. This is one of
Yes.
the most bad drawback of the cross-diffused ectopia. And sure,
Okay.
it is maybe يعني predisposing for
Most,
infection.
yes,
Don't.
infection, multiple infections.
Yes, thank you, doctor. Next candidate.
Yes.
You're welcome. Doctor,
Uh,
this is a static image.
Static image.
Yes.
This is a single static image plane study with intravenous contrast in arterial phase that's showing that there is a perinephric stranding surrounding the medial aspect of the kidney and involving the upper ureter and the renal pelvis.
What else?
And there is also surgical emphysema is noticed as the posterolateral aspect of the
Okay.
back.
So,
And
okay, very nice sign. What's the indication when you see surgical emphysema like this in a patient like this? What you are thinking
could
about?
be I'm asking for the history if there is a
No
possible
history.
renal biopsy.
By the way, no history.
Okay, if there is a renal biopsy first, or this is post-traumatic.
Excellent. Compare this by this, please. What?
Okay, if there is hypoperfusion of the left kidney in
No
relation to the
perfusion.
right kidney.
No perfusion at all. Why? What happened here?
Avulsion, maybe avulsion of renal pedicle.
Excellent. Excellent. So this is renal vascular pedicle injury or avulsion. Thank you, doctor, so much. I think, what is your next step?
Next step, I will see first if there is delayed image. I will wait for delayed image for 15 minutes or more to see if there is extravasation of the urine, so I can.
Excellent. I think this kidney is still alive or necrotic kidney died. See the artery? I think the artery completely lost. Okay? You are correct, by the way, but the first priority for the arterial supply. So, what do you think is the next management?
Next management, I will call the interventionist radiologist to see if there is. I will do DSA, and if there is thrombus, maybe it is a thrombus, not complete obstructed.
So we will.
Physical.
Thank you. This is very correct. So we will focus, in my opinion, we must focus our effort at the first for reperfusion. Okay? At least tell the examiner like this. We will call the vascular, renal, and interventional to assess the possibility and utility of revascularization. Okay? I'm also speaking about this limited study because, by the way, my colleagues, do you know many of the examiner will give you a static image? I forget to tell you, many. I think 50% of the images will be static. See, 50 to 40% will be static and very clear. You will look, you will find one, two, three, especially the first cases. Thank you, doctor. Next candidate.
Yes, that's me coming at the end.
Okay. What is this, Dr. Nagam?
Oh, okay, there is widening of the pubis symphysis.
Yes.
Okay, rest of the bones are grossly unremarkable. So this is, I think the urinary bladder is going to be in an ectopic position,
Okay.
located superiorly. So this is called, I couldn't remember the name actually.
No problem. Look here. Static image. Look here.
Okay, so there are bilateral atrophic kidneys. Yes, there is left
The kidney.
iliac fossa kidney, ectopically located, or
Yeah, the kidney is this one. Okay.
yes.
What happened for the muscle? There are any muscles?
They are no, there are no muscles.
Especially anterior abdominal wall. This is very characteristic to this syndrome.
So yes, Brown-Belly syndrome.
Excellent. What is the name again?
Brown-Belly syndrome.
Brown-Belly syndrome.
Okay, there is loss of the muscles, the abdominal distension, renal failure,
Yes.
and ectopic urinary bladder.
Yes.
Abnormality in the scrotum as well. There is abnormalities regarding the testicles.
Yes. Well, okay. Okay. What is the abnormality of the testis? Crypto or kidism?
Yes, yes.
This patient is 30-year-old. Due to the abnormality of it is associated with reflux. So both kidney are atrophied, and this is a transplanted kidney. Why? There are surgery here. Okay, but look here, absent or very atrophic anterior abdominal wall. Again, my colleague, a Brown-Belly syndrome. A Brown-Belly syndrome has at least 3 components you must talk about in the exam. Number one, absent or very weak anterior abdominal wall. Number two, weakness due to the weakness of the post-ureter. See, Brown-Belly is a disease of muscle weakness, anterior abdominal wall, and muscle of the ureters. So bilateral dilated ureters and renal and the subsequent renal dysplasia, and bilateral undescended testis. Okay. Again, how to remember Brown-Belly syndrome or Eagle syndrome? It is a disease of weak muscle, either skeletal muscle here, either the muscle of the ureter, whatever, where is the ureter? I see the ureter. There are not. I see. Okay. See the ureter.
Yes.
So
yes,
the
dilated tortuous reflux.
Yes, the kidney is at the age of 30 non-functioning, and cryptorchidism, which means undescended testis. This is the most common triad. Okay, my colleagues.
Okay, thank you so much.
Thank you. Tomorrow we will meet again. Thank you for all of you. Thank you, Dr.
Thank
Nahum.
you, sir.
Thank you.
Thank you so much.
You're welcome.